Secondly, we want to look at distributive shock. When it comes to looking at somebody with this type of shock, you can see this patient have a core temperature higher than 38 degrees Celsius or 100 degrees Fahrenheit, or lower than 36 degrees Celsius and 96.8 degrees Fahrenheit. They'll have a heart rate more than 90 beats per minute, a respiratory rate greater than 20 breaths per minute, or arterial carbon dioxide tension, or PaCO2, of less than 32 millimeters per mercury. Also, they'll have a white blood count of greater than 12,000 or less than 4,000, or more than 10% of their immature forms or bands. When it comes to hemodynamic monitoring and findings, the use of a pulmonary artery catheter was a standard for care of for decades. However, data now suggests an increase in mortality with the use of the pulmonary artery catheter monitoring. So now they stick with the atrial monitoring, such as the pulmonary capillary wedge pressure via Swan-Ganz catheter, and the cardiac output to monitor the patient. A typical pulmonary capillary wedge pressure seen in this condition would be either normal or decreased, which would be less than 4 torr, and a cardiac output normal or increased, which is greater than 2.2 liters per minute. When it comes to pharmacology to treat this, they need a vasoactive drug such as norepinephrine or dopamine to treat it. The norepinephrine increases mean arterial pressure, or MAP, is effective circulating blood volume, which is effective in circulating blood volume and venous return and preload with minimal increases of heart rate and stroke volume. The dopamine stimulation causes renal and visceral vasodilation and inhibits norepinephrine reuptake at the synapse. It is used as a vasoconstrictor and contributes with individuals dealing with low cardiac output or bradycardia. Now, for when it comes to oxygenation and ventilation, mechanical ventilation, oxygen should be administered via a mask. And in patients with alternate mental status, or AMS, respiratory distress, or severe hypotension, elective endotracheal tube intubation and mechanical ventilation should be considered. These avoid emergent intubation in events of subsequent respiratory arrest. Mechanical ventilation can also aid in hemodynamic stabilization by decreasing the demands posed by the respiratory muscle in the circulation. As far as ABGs are concerned, I believe the patient would have a type of metabolic alkalosis given the respiratory distress that comes with it.